urologists tend to just operate. That's really their forte and interest. And they usually refer patients very early to medical oncologists, even before any evidence of distant metastatic disease, sometimes with just rising PSA after either surgery or radiation. So I certainly have a lot of experience in hormonal therapy and various aspects of that treatment modality. So this is the slide that I think a lot of you have seen, kind of basic demographic aspect of prostate cancer. The bad news is that there's a lot of cases, more than 200,000 per year. The good news is that mortality tends to be relatively low in comparison to incidence. So contrary to, or opposite to a lot of other tumor types where sometimes the new cases almost equal the mortality, unfortunately. In prostate cancer, it's different. So most patients are either cured from prostate cancer or essentially outlive prostate cancer. And so the mortality, even though in absolute terms is high, it is relatively low in relationship to total number of cases per year. Now, probably a lot of you guys who come here to this forum, you've seen this picture. This is a guy who really gets credit for major breakthroughs in the treatment of advanced prostate cancer, particularly application of hormonal therapy. So his name is, or was, unfortunately, he passed away, as you can see, in '97. He's Charles Huggins, who was a urologist at the University of Chicago, who started his career there in 1930s, I think early 1930s. He was from Canada. There's actually a very interesting story. If somebody likes the history of medicine, and I highly recommend the book about the history of cancer research called Emperor of All Maladies, History of Cancer Research. If you haven't heard about this book, I think it's really worth reading because it gives you a great perspective on the history of cancer research going back to literally briefly to antiquity, but then primarily focusing on the 20th century. A lot of very interesting stories about researchers and patients that were involved in early discoveries of cancer treatments. And there was a very interesting chapter about Dr. Huggins, how he as a young surgical resident came to the University of Chicago in the early 1930s, and at that time, the times were definitely different, and apparently the chairman of surgery, of overall surgical department, essentially told him that, Charles, you're going to be the new chair of urology. And there was nobody there. He was the only member of the urology department. And he apparently said, well, I've never operated on any urologic patient, but I don't know anything about it. And he just said, don't worry about it, you just learn as you go along. And he became a chair. But he was an incredible guy. He, as it says here, eventually won a Nobel Prize in medicine in 1966 for his discovery of hormonal therapy, the relationship between testosterone, estrogens, and a lot of hormones that affect testosterone levels, and its relationship and effect on prostate cancer. So he was a skilled surgeon eventually, but he was mostly a lab guy. He liked kind of hardcore science, and that was his forte. So he really is the first guy, and I apologize for a lot of these very kind of scientific looking slides, but this is what we medical oncologists do, unfortunately. We deal with a lot of these cancer pathways and try to describe how a lot of the various mechanisms of cancer growth and resistance play out. So we deal with, I think this pointer may not work that well. Let's see. Look. You know what I'll do? Maybe I'll use my pointer. Yeah, it's kind of weird. Anyway, hopefully it's not maybe needed. Maybe Russell can educate me again. Hold here. Press it. Bottom. Yes. Press that. Oh, okay.
Oh, that's all you need to do is just press that. Just lower trigger. Just like a trigger. Press the trigger.
Move this one too.
No, just the lower. Just this one.
This one. Awesome. That actually works. Perfect. Thanks, So anyway, so this is kind of the very simplified mechanism of action of testosterone and how it stimulates the receptors in the cancer cell, and eventually that leads to activation of some genes inside the prostate cell. I don't think we need to go to a lot of details, but this is kind of what Dr. Huggins was working on. He really described the relationship between testosterone and other related hormones and how they stimulate prostate cancer growth, and with that determined that anything that can interfere with that pathway, with that testosterone DHT, which is the product of testosterone, that's signaling through this AR, which is androgen receptor, anything that can break that pathway can lead to beneficial effect on prostate cancer, on slowing down the growth and so on. And he published his pivotal paper in 1941. So this is, I think, very humbling. I mean, this is more than 70 years ago by now in Archives of Surgery, that and this was based on laboratory observations, first in cell lines and animal models. He noticed that if you either remove the testicles in animal models affected with prostate cancer that metastasize, or administer estrogen, which he already determined that if you administer estrogen to these animals, it lowers the testosterone through a variety of feedback mechanisms. He actually showed these dramatic responses. And this is just an excerpt from his article in Archives of Surgery in 1941, when he says patients gain from 3 to 18 kilograms, so multiplied by 2.2, that's in pounds, in weight. Their appetites and red cell counts increase, so anemia is resolved. In 9 of 11 patients with severe pain, complete or nearly complete relief of pain was achieved and maintained. Some of these patients were previously bedridden and barely able to eat or move, mostly from pain, from metastatic cancer to the bones. And he concluded that improvement that he saw was greater than the authors had observed in any case in which far advanced or metastatic carcinoma was treated in any other way. So really, when you think about it, this probably ranks with one of the most pivotal, important discoveries in cancer research in terms of impact on patients, on relief of suffering, on really durability of this discovery. Because as I will talk about later, in many ways, what we're doing these days is really variations on the same theme. It's a derivative of this discovery. We are still kind of milking, really, the discovery of Dr. Huggins, trying to refine the hormonal therapy treatments. We're certainly going beyond that, hopefully, but this still remains real mainstay of therapy. As a lot of you know, and I have no doubt that some of you probably have been or are even on hormonal therapy right now, it is initially very highly effective in 90% of patients or so. Now the problem is that, as with a lot of cancer therapies, on average, the good benefit of this therapy lasts for about 2 years, and then resistance starts developing. Although it is always important when you talk about averages to really not to maybe focus too much on that number. It gives you kind of a sense. But as you can imagine, there's a huge variability there, and there's wide range. I mean, there are patients rarely, as you can see, in about 10% that actually will not even respond to hormone therapy. But then there are about 25% of patients that will respond to standard hormone therapy, something that lowers your testosterone level for 5 years or more. And I certainly have patients in my practice who've been on just drugs like Lupron, Zoladex, nothing else. Patients who had extensive bone metastasis who've been on that kind of therapy for 10 years plus, and they're doing very well. So certainly that therapy can be extremely durable, but it's not a rule. So usually some sort of resistance starts developing after a few years. And this is, again, one of these maybe slightly difficult slides. I took it from Nature paper, Nature Cancer. So this is actually getting a little bit old, this slide, but I think it's still pertinent. It kind of describes some of the potential mechanisms of resistance that exist there, how cancer cells try to bypass the suppression of testosterone. So one of the possible ways is the development of this so-called hypersensitive mechanism. And what that essentially is, that cancer cells start producing more and more androgen receptors. So these are these proteins in the cell that bind testosterone. And then downstream, they result in activation of the variety of genes. So if you produce more and more of these receptors, you can actually have less testosterone and still stimulate this whole pathway. So this is so-called hypersensitive pathway, just more androgen receptors. That is present in about 30 to 50% of prostate cancer patients who develop resistance to hormone therapy. Then something called promiscuous pathway. So this is a very frightening phenomenon, and it really is seen in other tumor types. For example, in breast cancer, the similar types of mechanisms exist. When you have androgen receptor here in this orange color that mutates or is modified, just changes a little bit in a way that that area, that pocket in which the testosterone or other hormone is supposed to bound, changes a little bit, and now it can be stimulated not just by testosterone, that hexagonal molecule in purple, but a lot of other protein or a lot of other hormones. And they are listed here. For example, flutamide, bicalutamide. So these are the agents that are supposed to inhibit, block that receptor. In fact, over time, cancer can learn how to use them. And this is the way the cancers are. They adapt. They discover a way to actually use the weapons that we're employing against them to their own advantage. It turns out that corticosteroids, so agents like prednisone, decadron, in some cell lines you can show that this receptor can mutate or change in the way that simple prednisone can start stimulating prostate cancer growth. And then you have some other pathways that I don't want to bore you with that essentially describe this phenomenon that you really don't even need testosterone or any other hormone in that pocket. And there are a variety of other pathways that we know from other tumor type biology, for example, in breast, lung cancer, that those pathways start firing downstream and start actually activating androgen receptor without any testosterone, and again lead to further growth of prostate cancer cells. So these are just examples of how prostate cancer cells can develop resistance to standard methods that we use initially when we lower the testosterone level. So we've obviously been frustrated with the developments of androgen resistance for decades, and this is a list of agents that were tried just relatively recently from different types of compounds that were employed in clinical trials to try to really use maybe some other weak points in prostate cancer biology and try to circumvent that resistance to hormonal therapy. And you might have heard about some of these agents, GVAX, this vaccine, calcitriol is essentially vitamin D. These are agents that block formation of blood vessels, zibotentan, atrasentan, bevacizumab, satraplatin is a chemotherapy agent. So these are just 1, 2, 3, 4, 5, 6 examples of agents that were very extensively tested, based on very reasonable laboratory data that we were hopeful would actually be beneficial in prostate cancer, and this was all a bust. Essentially, all of these agents failed in clinical trials, and really, within those years, 2004 and 2010 or 11, there was really only one agent that was approved, and that was a chemotherapeutic compound called Taxotere. And probably some of you might have heard or even been treated with this agent. Certainly helpful, still used very extensively, But this was really, in that time span, the only agent that has shown some real meaningful benefit in terms of survival improvement and improvement in symptoms of patients. But this is taxotere is a chemotherapy agent associated with a lot of side effects that we know of in terms of what chemotherapeutic agents do. So I think that probably, maybe it's just coincidence, but I think a lot of these failures with these different types of agents, I think led a lot of scientists to conclude that, well, if all of this doesn't work, maybe we should go back to hormone therapy. Maybe that's what we know really at the best, that we know that works. Maybe we should refine that more. Maybe there's more to it that we know. And indeed, this is how I think recent discoveries have kind of transpired. That a lot of what we've discovered, and a lot of agents that Russell mentioned at the beginning that were recently approved are really hormonal agents that are just maybe better and utilize some different nuances in this hormonal pathway than before. And this is kind of a general summary of physiology of testosterone that helps to explain how some of these new agents actually work. So you probably are aware, this is, if you haven't figured it out, these are testicles. So this is the main source of testosterone in the body, about 90%. We've known that for decades. This goes back to Dr. Huggins' data. This is an adrenal gland. So this is a triangular gland that sits on top of the kidney. We have known also that that produces maybe about 10% of testosterone. So over the last several decades, we kind of knew how to block the sources of testosterone production from these two organs. So one way to eliminate testosterone here, obviously, is cut it out, surgical orchiectomy, the removal of the testicles surgically, or agents that chemically block the production of testosterone in the testicles, like lupron, Zoladex. And then the agents that may interfere with production or effect of residual testosterone that is still made in adrenal gland. So you probably also heard of agents like Casodex or bicalutamide or ketoconazole at high doses. So ketoconazole would block the formation or production of testosterone and other androgens in this organ. Bicalutamide or Casodex would prevent it from binding into the prostate cancer cells. But one of the mechanisms of resistance that emerged from some research that I haven't mentioned in this previous slide is the fact that it appears that prostate cancer cells, over time, when you deprive them of other sources of testosterone from outside, from natural sources of testosterone in the body, testicle and adrenal gland, believe it or not, they start making their own testosterone. So this is, again, another example of this perverse way that cancer cells can adapt. So they don't have testosterone that they like for growth. Over time, if they realize that, they develop enzymatic machinery. They actually start synthesizing enzymes in their cells that actually can produce their own testosterone for further growth. And they can use either precursors that are in the blood, like DHEA or androstenedione, or actually they can synthesize the testosterone from the scratch, from testosterone, from cholesterol. Cholesterol is the first building block for testosterone production. So these are some of the, again, these are very scientific slides, but I thought it kind of illustrates very nicely that phenomenon that, on the x-axis you have variety of samples from prostate cancer specimens. P essentially indicates that this is a prostate specimen. So these are actually just normal prostate gland samples from biopsies. C letter indicates cancer samples, but from the prostate itself. And these are samples here from patients who actually had biopsy from their metastatic sites. And these were the patients that were already treated with hormonal therapy. So they were already on lupron, or they had their testicles removed so they could orchiectomy. So, and as you can see here is the testosterone level. And in those specimens from normal prostate or even prostate cancer that is localized, just confined to the prostate, testosterone levels are low. However, if you test the tissue samples from metastatic sites, so these are biopsies of patients, supposedly here, the circulating testosterone is extremely low. But you can see that the testosterone concentration is higher than in those normal prostate samples or localized prostate cancer. So this is a study that was published in Cancer Research several years ago by Dr. Montgomery from Seattle that essentially really opened up that field to realization that either metastatic prostate cancer sites act as a sink for circulating testosterone. Somehow they accumulate testosterone and act as a sponge for testosterone, and that can stimulate the cancer growth. Or, as I mentioned before, they may in fact have developed enzymatic machinery that allows them to make their own testosterone on the site. And the latter is probably true, and this is just a slide again for those of you who are not scientists or biologists. It may be a little bit difficult to interpret, but just to simplify, I will just point that this more intense color indicates the staining for a specific enzyme that is critical in the synthesis, in the formation of testosterone. And as you can see, the intensity of this brown staining from the metastatic sites indicates that there's a lot of this enzyme in those tissues versus normal tissues or primary prostate cancer tissues. So that again is a supporting evidence that in fact there are enzymes that support the chemical reaction of synthesis of testosterone in this metastatic hormone refractory or castrate-resistant metastasis. In this particular case, the enzyme of interest is called alpha-fetoreductase, but there are examples of other enzymes in the pathway of testosterone synthesis that are also present in the very high concentrations in these metastatic sites. So that really led to discovery of some of these agents that you've just heard about that were approved within the last couple of years, like abiraterone or Zytiga. So again, this is a relatively hardcore kind of biochemical pathway illustration, and I certainly don't want to, again, bore you with the details of it. Only to mention that among several enzymes that is important to synthesize testosterone, to actually produce testosterone, you can see there are a variety of steps in this synthesis, very complicated. But there's one enzyme that seems to be really the central player and the key enzyme, and it's called CYP17. So essentially, wherever the testosterone in the body is produced, that enzyme has to be present, whether it's in the testicle, adrenal gland, or in tumor tissues. So this enzyme is significantly active in prostate cancer cells. If you can block it, you can definitely do some good, because you will shut down the production of testosterone much more effectively than agents like lupron or even orchiectomy, because it not only addresses the production of testosterone in the testicle and adrenal gland, but wherever it takes place. So in early studies, it turned out that application of this enzyme, this blocker of this enzyme rather, really inhibits or slows down testosterone production to essentially undetectable levels. So just as an example, if you're just on lupron or you've had orchiectomy, your testosterone level is going to be typically maybe in the 20s. When you measure it in the blood, 20 nanograms per deciliter up to maybe 50, even sometimes a little bit more. If you treat the patient with Zytiga, it drops to 0. So essentially, you cannot detect circulating testosterone anymore. And the same happens in the tissues. So everywhere where the testosterone production is taking place, it's shut down. So this led to very aggressive clinical development of this compound, abiraterone. British beat us into it. They actually are the ones who had this compound in their inventory, although eventually it was licensed to a company here in LA called Cougar that clinically developed this compound and then sold to Johnson & Johnson. And this is just a schema of the clinical trial that was conducted that led to approval of this agent. And initially it was tested in very advanced patients with prostate cancer who not only failed hormone therapy, so CRPC means castrate-resistant prostate cancer, but also failed one or two chemo regimens. So at that time, I remember when I was being approached by a company to open that study at the City of Hope, I was very incredulous because it seemed very counterintuitive. Why would you want to try another hormonal agent in patients who already failed hormone therapy? Not only that, but I also failed chemotherapy. How in the world that would even work? I thought it was almost impossible that would be effective. But I think this is really the brilliance of people who discovered that agent and analyzed it initially, and also it kind of coincided with this better understanding that the testosterone continues to play a role, even if you have Lupron on board, even if you have Zoladex on board, that the cancer cells can make their own testosterone. That's one of their mechanisms of resistance, and if you can block it, you in fact can still help these patients, even in those very advanced cases where seemingly hormone therapy would not be thought to be very likely to help. And when they conducted the study, they showed significant advantage in survival in patients who were treated with abiraterone or Zytiga now versus placebo. Again, I know sometimes when you look at these curves, it kind of looks disappointing because you see the difference of, what, only about 4 months or so in survival. So, but again, be always very careful about reading median survival improvements. Just because in the study the improvement in survival was about 4 months, it does not mean that if you need this drug and if you're on this drug, you will live just 4 months longer than being nothing. This is just average. So some patients may get absolutely no benefit, unfortunately, while some may be on the curve like that they can gain 1, 2, or more years. And when we finally bought to this concept and we opened the study at the City of Hope, I've had several patients who've been on this drug for 2 years plus, and they clearly had excellent prolonged control of cancer even after failing standard hormonal therapy. So again, don't necessarily despair that this is 4 months only, because yes, it may be on average 4 months, but some patients, again, there's so much variability among patients that some patients can get significant mileage out of this compound. And this has been approved by FDA, it's pretty widely used. Now, that original study that I mentioned was tested in patients in post-chemotherapy setting, and that's how FDA initially approved it, but the company then performed a relatively quick follow-up study in castration-resistant prostate cancer before chemotherapy, which frankly would make more sense to use it earlier. And this was just recently published in New England Journal of Medicine and led to approval of this compound also in the pre-chemotherapy setting in December of last year. So this is the kind of the tabulated data of survival and other data from the study. So the median overall survival has not been even reached in abiraterone. So that means that the curve is so flat that the 50% mark has not been reached yet, versus placebo patients lived only a little more than 2 years. So very highly statistically significant improvement in all other elements that you like to measure. For example, pain relief, need for radiation therapy, need for pain medications, all were diminished in patients who were on abiraterone. So abiraterone is now approved for patients who failed standard hormone therapy, Lupron, maybe Casodex, they don't even have to fail it. They can be switched to abiraterone and added that the agent is very well tolerated. It has to be taken with a low dose of prednisone to prevent some of the side effects. But for the most part, in my experience, it has not resulted in any major problems. The other agent that Russell mentioned that's just been approved is Xtandi or enzalutamide. So this is also an agent that falls into this hormonal category. Again, going back to Dr. Huggins' concept. So this is 2012, 2013, and we're still exploiting the same pathway, just just synthesizing better agents. So enzalutamide, or Xtandi, it's a trade name, is an inhibitor of androgen receptor. So while Zytiga shuts down the production of testosterone, this agent does not affect the production of testosterone, but it prevents whatever testosterone is still in the body from exerting its signaling effect on androgen receptor. So this is more similar to an agent Casodex or bicalutamide that some of you may be familiar with. It has on the surface somewhat similar mechanism of action. The difference is that this is 100 times more potent than Casodex. So it really has significant advantages. I don't know if I want to really spend that much time specifying these differences, but maybe I will. Although this is, I know, a very complex slide. But it kind of shows potential sites of action where this agent can exert its effect, and compare them to bicalutamide, which is Casodex. So both of these agents, bicalutamide and enzalutamide, this is an old name for it, MDV3100, as I mentioned, they block that particular site. They prevent binding to androgen receptor. But what also, so this is here, the binding site. Both agents, bicalutamide and enzalutamide, block that, but enzalutamide does it 100 times more potently. Also, what happens is that even if this, if the testosterone can somehow overcome that mechanism and binds to androgen receptor, with the bicalutamide, it can still move down to the center of the cell and bind to the DNA and start doing its job. With enzalutamide, it actually prevents additional steps that are required for this whole complex to start activating cancer growth. So it prevents transmission or movement of this whole complex down into the cell. So even if the testosterone can overcome this step, the enzalutamide binds this step, which bicalutamide does not. Even if this whole receptor complex can still move down to the DNA, in the vicinity of the DNA, in the center of the cell, the enzalutamide prevents this complex from binding to the DNA. So it really has two additional mechanisms of action beyond Casodex that makes it much more effective and much more potent. And when this agent was, and this is actually an agent that was really discovered by, this is another LA kind of compound, because really who gets credit for the discovery of it is Dr. Charles Sawyers, who some of you probably have heard. He was at UCLA for many years. Unfortunately, they recruited him to New York Memorial Sloan Kettering Center several years ago. He's a brilliant scientist who really, his team synthesized this compound, and when they applied it in early clinical trials in patients who failed all kinds of therapies, including standard hormone therapy or hormone therapy and chemotherapy, those bars, vertical bars going down, indicate patients who had declines in PSA. So as you can see, vast majority of patients had declines in PSA when this compound was applied to them. Only a small minority of patients would have increases in the PSA. So those are the vertical bars going upwards, and the percentages describe the percent drop in PSA. So as you can see, some patients actually experience 100% decline in PSA level. Again, those are patients who already failed Lupron, or failed Lupron and chemotherapy. And you can still, by applying powerful hormonal agent, you can still have incredibly strong biological effect. So that led to the large clinical trial again that we at the City of Hope at that time, because we knew how active abiraterone or Zytiga was, I was much less skeptical at that time that, hey, those agents are actually really worth something. We should get access to it for our patients. So we participated in this large study. We were one of the large accruing sites internationally. And this was again tested in patients who failed standard hormone therapy, so castrate-resistant prostate cancer, and also chemo. And they were randomized to enzalutamide and dreaded placebo. Unfortunately, some of these trials, if they really want to show survival benefit, you have to use placebo control. And it was very interesting because when I was seeing these patients, so you don't know actually if these patients are on placebo or on real drug. They are blinded. We are all blinded. Only central investigators located centrally can have codes that know who is on what drug. And there's no bias. Nobody knows. So it's very objective evaluation of benefit. But what was really striking to me that initially the drug is really so well tolerated that you could not tell. I mean, usually you could tell sometimes by side effects whether somebody is on real drug or not. You couldn't. So I could not tell if somebody was taking real thing or placebo until we were doing, after 2 or 3 months, we were doing scans and PSAs showing, hey, if somebody's PSA dropped from 100 to 1 and their bone scan improved and lymph nodes decreased in size, you kind of knew that they were on the real thing. And then in November 2011, there was a press release stating that there was an interim analysis performed. So this is kind of built into the protocol when they actually look at the data kind of in the middle of the study to see if it's looking good, and if it does, they really close the study because it's not ethical anymore to keep going with placebo arm. So we were notified that the study is being what's called unblinded, and you have to offer, yes? You have a question?
In your study, did you compare, in your study, did you compare the one that just approved with Avodat?
No, no. This was just placebo here, so this was a sugar pill.
Okay.
Avodat, even though as some of you know, it's a hormonal agent that's used primarily for benign prostate enlargement, may have some effect in cancer, but no, it was not compared to Avodat. Yes. This was thought to be true advanced disease. I mean, remember, these are patients who have metastatic disease, bone lesions, failed Lupron, failed Casodex. In 80% of cases, they failed Casodex already. They failed chemo. So the feeling was, Avodat probably, as much as it's an interesting agent, probably will not help with this.
Because it worked for about 1 year after that. It's the same reaction that prevent the attached to the cancer cell. It worked about 1 year. After that, it doesn't work anymore.
Yeah.
That's why I thought, is it the same thing, the same mechanism or not?
It's a different mechanism. Avodat, some of you may know, it kind of prevents conversion of testosterone hormone to more potent hormone called DHT. It's an interesting compound. I'm glad you're responding to it, and I can talk to you. I don't want to necessarily ask you about the details of your case here in front of everybody. But yes, it does work occasionally. In my experience, I would say that in these kind of patients, not a common situation that I would work, actually.
Thank you.
Yeah, but I'm glad it's working, of course. And if it's working, don't break it. But anyway, so essentially, what we did here was that we were told, hey, whoever is on placebo has to be offered the real drug because it's no longer ethical to do it. And we obviously did. We had a few patients on placebo that we treated with. These are just survival curves, again, showing a difference. And I don't think we need to spend too much time. There was, again, 5 months, roughly, difference in improvement on average in extension of survival. Now, you also have to remember that what happens in those studies, I don't want to spend too much time on it, but I think it's important to maybe explain, because sometimes even physicians don't understand this concept of median survival improvement and what's involved in it. As I mentioned here, in this study, when the study is unblinded, then the patients who are on placebo arm are offered the real drug. So really, this is not a pure study that compares active treatment versus no treatment forever. Eventually, all of these patients, when they show signs of worsening of disease, they get a lot of different drugs subsequently, including this one, just maybe delayed. So that can clearly narrow the difference in survival, because obviously this drug is working. If you start giving it later on to these guys, they will live longer. So that's always important to remember, that 5 months is essentially, it's a study between enzalutamide and in many ways delayed enzalutamide. So if you were really being cruel, which is impossible and unethical, if you just prohibited those guys from ever seeing enzalutamide, the difference would be much more significant. There are a lot of other hormonal agents in development. Probably the one that is furthest advanced is this drug called TAK-700 or Teronel. This is another inhibitor of this key enzyme, so somewhat similar in mechanism to Zytiga, to abiraterone. But supposedly, at least according to the company, it has some advantages, maybe a little less side effects, maybe a little bit more potent. It remains to be seen. We've also participated in the studies, 2 studies with this drug that were completed, and it may be reported within the next few months. I frankly would not be surprised if this drug is approved. It has a very similar mechanism of action to abiraterone. It may be a little bit more potent. So look out for this drug, TAK-700 or Teronel. Probably my expectation would be that it will be reported within a few months, probably approval likely within a year or so. Again, this is my speculation, so take it with a grain of salt. There are some other interesting agents from the hormonal category. This one is very similar to enzalutamide. This is a little bit earlier in development, but supposed to be more potent than enzalutamide. This is another compound kind of originated from Dr. Sawyer's lab that is very highly advanced. Moving along to other types of therapies, I think you've probably heard about Provenge here before. This is just maybe putting it again in context of these other therapies. Provenge or Sipuleucel T is an immunotherapy compound. So it's really a way to activate your immune system to fight prostate cancer. And immunotherapy really has been the holy grail of cancer research for decades, with some spectacular failures for forever. You can think, go back. But it makes perfect sense. How can we harness the immune system to really fight cancer? This is a more natural way. The problem with the immune system that it's really not designed to fight cancer very well. It may at the very early stages, but once the cancer escapes the immune surveillance, it doesn't recognize that cancer cells are foreign tissues. It thinks that these are just normal tissues. It doesn't have capability to really sort out between normal body cells and cancer cells. So you really have to help them to see that these are intruder cells that they need to be eliminated. And the way it's done, and probably you've heard this before, is that you essentially use patients' own immune cells called antigen-presenting cells. Those are subsets of white cells. So when you have your blood count measured and you look at the labs and you see WBC, so white blood cell count, the subset of that is not usually reported separately, but somewhere it's buried in that number, are these so-called antigen-presenting cells, or dendritic cells. So we have a technology now that we can filter those cells out of the bloodstream through the IV, separate them, store them, and then you can incubate them at warm temperature with this artificially generated protein that contains, in this orange part, prostate acid phosphatase, so that's PAP, and this is this blue one. Blue part is called GM-CSF, it's immune stimulant. So when you incubate these your cells with this protein, it gets picked up, it gets internalized, it's soaked into the cell, and then over time, over 24 to 48 hours, it's actually presented or expressed on the surface. That orange protein, PAP, prostate acid phosphatase, is presented on the surface. And this cell is kind of like a quarterback of the immune system. It really regulates the immune response and presents foreign tissues, foreign proteins to other elements of the immune system. And when it becomes activated like that, You can see it on the microscope, and there are several markers that you can measure. That cell now has these prostate proteins expressed at the end of these protrusions. So they can be very effectively presented to the other elements of the immune system. Now you infuse this to the patient. So you infuse about 50 million of these cells that are now activated. They were collected, and when they get into the circulation, into the tissues, they start recruiting T cells. So T cells, that's another aspect of your immune system that's involved in fighting viruses and so on, infections. But here, it essentially teaches these cells, it activates them to start fighting prostate cancer cells. So this is Provenge molecule. It teaches the immune system to fight, surround, and damage prostate cancer cells. That's presumed mechanism of action. This is probably a subject for a separate presentation. And this compound, as some of you well know, generated a lot of controversy over the years. This is kind of a schema how it's done. So this is the first day, it's leukapheresis. So this is a collection of these immune cells from the patient. The patient sits in the chair connected to the machine that looks like a dialysis machine. It takes about 3 hours. Usually it's done at some sort of Red Cross facility or some sort of blood bank facility. And once it's collected and put in the bag, shipped to the processing facility that actually is in Seal Beach, as some of you may know here. There are only 2 in the country, in Atlanta and in Seal Beach. And it's incubated, and this whole activation of these cells takes place in the dish. And here we don't have to use plane, fortunately, for this. It's within driving distance. And you can ship it back to the clinic, and it's actually infused back to the patient, kind of like a regular blood transfusion. It takes about an hour. And you repeat it every 2 weeks times 3, and that concludes the whole treatment. That's it. You're done. You're never going to get it again. It results in gradual activation of the immune response against prostate cancer. And that was studied in this clinical trial that we also participated in, that showed, again, the average survival patients who got it was improved as compared to people who got placebo. When they've actually done, so this again is relatively small difference on the median kind of way of looking at it of approximately 4 months. When they actually did the subset analysis in the subsequent looks at the study, patients who had a PSA level of less than 22, so they had to have some evidence of metastatic disease and relatively no symptoms, so no pain, relatively low volume cancer. When you have PSA of less than 22, the survival improvement was more than a year. So even though it was kind of a look back at these patients, I would say that probably the best candidates for these treatments are patients who, as of now, as far as FDA label, patients who have gone through castration or lupron therapy, have shown some evidence of resistance to it with rising PSA, have something on scans that you can point to and say, okay, probably that's the cancer spot, but they're really feeling well. They don't have pain, they don't have symptoms, and they have relatively low PSA by medical oncology standards, at least less than 20 or so. That would be probably the best candidate for Provenge immunotherapy, that you can expect probably the best improvement in longevity from it, in improvement in survival. The mystery about this compound is that it doesn't seem to lower your PSA, which is frustrating, because that's how we measure disease a lot, and it can. I've had certainly patients, I've treated maybe 70 plus patients with Provenge so far, and I've seen some declines in PSA, but they are not usually dramatic, and they are usually slow. So it sometimes can happen like 3-4 months later. So you have to be really patient, and also not to have the situations where you have patients with very aggressive cancer that's all over, causing symptoms. You don't have time, frankly, to wait for Provenge to work. You want to, in those kind of cases, you may want to use some other agents that will actually shrink the cancer faster. So that's the kind of important aspect of this treatment. If you're going to use it, try to use it as early as it's allowed by FDA label. It's another expensive compound, as you might have heard. Moving along, nobody wants to talk about chemotherapy anymore. That's almost like a passé. Like we're definitely moving away from chemotherapy. I think that's the trend that we're going to see, that because of the side effects, difficulty dealing with those agents and how the patients feel, it's really it's being pushed down the line of options further and further. However, I still would have to say that agents like Taxotere, that's been around since 2004 as far as approval for prostate cancer, or this newer derivative of Taxotere called cabazitaxel, do play a role. And if you're really having difficulty thinking of other options, I would not dismiss those agents. Cabazitaxel is really, as you can see, chemical derivative of docetaxel. It has only a couple of different chemical groups. However, it really imparts totally different chemical properties. It is derived from needles of the yew tree, but it does behave and act differently than docetaxel. It's really more potent. So it really has been studied. This is a schema of a study where they actually looked at patients who already failed docetaxel, again, or Taxotere, and they were either assigned to kind of older generation chemo, that's going back about 20 years when we've used this agent, and this is a new agent, cabazitaxel. Looking at overall survival, you can again see that upper curve patients on cabazitaxel, or Geftana is the name, lived longer, on average about 3 months or so, on average again. So, but I've used this compound in quite a few patients. In my experience, frankly, it seems to be better tolerated than docetaxel if you use growth factor support like Neulasta. So this agent that does cause a lot of decrease in your immune system responses. So certainly you would not want to cross-use it with Provenge, but maybe later, months later down the line. If you use it with growth factor support, my experience, the patient have less side effects than with Taxotere. You have no hair loss with it, no nausea, no vomiting, occasionally diarrhea is pretty mild, and the fatigue. The problem that I always experience as a treating physician is that you can deal with a lot of these side effects somehow, relatively easily with supportive drugs that we have now, but with fatigue, we really have very few things that we can do. And it really frustrates me because in our clinics, in our hospital, there's this push to talk with patients about fatigue, and we have these posters in our clinic so patients can look at and rate their fatigue. And they look at these posters and they tell me about fatigue, and I say, well, great, thank you, and there's really not much you can do about it. There are some tricks that you can try, exercise, obviously making sure that they're not anemic and so on. But really, in the long run, these chemotherapeutic agents cause this nagging and worsening fatigue over time. So in my experience, that's kind of the limitation over a long period of time. Moving on to some future developments. So I've really talked about several agents that were just approved by FDA in the last few years, but there's a lot going on, a lot of agents on the horizon. I've already mentioned that TAC-700 or Teranel that I predict will be approved. The other one that is making a lot of waves is this compound called cabozantinib, or XL184. It's an oral agent, so it's a pill. Don't be intimidated too much by this graph. It essentially tries to explain its mechanisms of action. What it essentially says that this agent seems to not only block the tumor cell growth, but it kind of really breaks down the interactions that happen between bone cells and prostate cancer cells. So there's a lot of crosstalk. When the prostate cancer moves to the bones, and bones for some reason attract prostate cancer cells. They like the bone environment. So that's why when we have metastatic prostate cancer, it almost always involve bones, and there are some proteins, enzymes that seem to attract prostate cancer cells to the bone environment. So this agent seems to interfere with this love affair, between bone and prostate cancer cells. It's an oral medication. It is relatively well tolerated at the doses that is now being studied in prostate cancer. Can cause a little bit of high blood pressure, sometimes a little bit of skin changes like blistering, maybe fatigue, but not to the degree that chemo does. So when they started testing it in the early kind of clinical development, so this was a lot of cancers, but they particularly noticed that in prostate cancer patients who had bone metastasis, there was 68% objective disease control, so lack of worsening at 3 months. So these are patients that failed essentially everything that we knew at that time. Chemo, standard hormone therapy. Almost 3/4 of them had decrease in size of cancers in the soft tissues. So that would be, soft tissues are essentially lymph nodes, lungs, liver metastases. What was probably most striking was, and I'll show you some pictures, complete or partial bone scan resolutions. So some patients had very extensive bone metastasis resolved. 67% improvement in pain. What is really intriguing and puzzling that all of these positive effects that you can document were not necessarily correlating with PSA responses. So that is, again, we are used to PSA as an ultimate marker of everything. And it's hard to get away from this, and I love when PSA goes down, but I think that may be one of these compounds that may not affect PSA that much and still be very beneficial, like Provenge. Provenge also is another agent that you can point to where PSA may not be going down, but there seems to be some advantage. So we probably have to keep that in mind, as hard as it is, that PSA is not everything. That there are, PSA in my mind is kind of, it's a good marker for a hormonal agent. When the PSA is going up, that means that this testosterone pathway is firing on all cylinders. So yeah, all those agents like Zytiga, like enzalutamide or Xtandi, they affect that hormone pathway, and you would really expect that the PSA decline will be a marker of activity. This doesn't really affect, this compound does not affect hormone pathway. It attacks cancer at a completely different angle. So I would not necessarily be surprised here where you could have cancer shrinkage and response, but the PSA is still being produced by some of these cancer cells that are surviving. Oh, what happened? I think I accidentally turned it off. But this is a bad timing because this is probably, these are some of the most spectacular. Perfect, yeah. So this is what I was going to show you. And you don't really have to be a radiologist to see what's happening here. So probably most of you have seen these silhouettes of bone scan. This obviously you can see the skull, the spine, ribs. All of these black spots are where cancer is located. Pretty dramatic. So this is when you apply this cabozantinib agent after 3 months. Never seen something like that before. Maybe once or twice with standard hormone agents that you can eventually get there. Usually we see maybe some fading of some of these. But to be essentially normal after 3 months is quite unheard of. So as you can imagine, that generated quite a lot of interest. These are some other examples. Representative images pre-post. This is the same, I think, that I showed in my different vision. Pre and post. Yes.
Yeah. Could you? This is very dramatic difference here.
Yes.
What mechanics, are causing this kind of change for the drug? I mean, maybe it's just your intuition, maybe
Right.
it's your observation. Could you share that with us?
Yeah, so that's a great question, and you know, I wish I knew, because at this point, I think the honest answer would be that I don't know for sure, and people are definitely looking at it. Now, what I would say that these are the scans. These are standard bone scans that use this technetium nuclear agent, radioactive technetium compound that is injected, and it has a structure that is somewhat similar to calcium, and it accumulates in areas in the bone that has increased activity, what we call metabolic activity. There's something going on there. It doesn't necessarily show the cancer. It shows what we think more of the reaction of the bone to cancer. But as you know, bone scans can be sometimes tricky to interpret because they also light up a little bit with arthritis. So that gives you an idea that it's not a totally specific scan for cancer. So probably what happens is that there is some sort of effect of this agent, as I mentioned, on maybe, to some degree, hopefully, we hope on cancer, but even more importantly, on the bone reaction to the cancer, which is typically not a good reaction. It's an inflammatory reaction. It's a reaction that causes pain. It's a reaction that actually creates potentially an environment where the cancer cells can find a lot of nutrients, a lot of enzymes to grow. So my guess, and you know, the rapidity of that is quite striking. This is 12 weeks. My guess is that it probably has a direct anti-cancer effect to some degree, and you can actually see it on other types of scans. So, for example, if you are looking at some of these patients with CAT scans, looking at soft tissues that I mentioned, they shrink as well. There's a significant proportion of patients that are shrinking, that the cancer is shrinking. So I think that's part of it. But in that dramatic fashion, I think it has to do with this interplay between the bone environment and cancer. That would be kind of the best way that I can describe this. Now, this agent is moving very rapidly into further testing in the clinic. We will, I'm not sure why it's doing this, but maybe it's a sign that I exceeded your patience. Probably it is. Yes.
Doctor, what is the connection between metastasis of cancer in the bone and arthritis?
Wow, that's a super intriguing question, and you know, I probably cannot give you a very intelligent answer. We know in general that inflammation is a potential nidus or a focus where the cancer cells can home on and like to grow. Because again, inflammation or even arthritis is an inflammation. So you have some sort of reaction going on, obviously in the joint, and some of these proteins and enzymes that are a result of arthritis process can enhance the cancer growth. So just give you an example of an experiment that you can do with mice. So let's say that you create the wound in a mouse model. You know, mouse, maybe you create ulceration in the skin, either with burn or some chemical. Then you inject cancer cells to the bloodstream. A lot of the times, they would start growing in that area of the scar and inflammation. So that's kind of an example where inflammatory reaction can attract cancer growth, and they like that environment as well. But having said that, so that's a laboratory effect, and that you kind of, you know, when you see that, when you see those kind of pictures or experiments, it definitely sticks in your mind. But does it mean, you know, that I've seen patients, for example, with prostate cancer that with metastasis to the bones that tends to home into areas of arthritis? I don't think so. In fact, it's very rare in real human beings. So typically we don't see metastasis in the joints where the arthritis can be. So did I confuse you enough? Or it's an intriguing question. I think there is a role, there's definitely tremendous interest in knowing and understanding reaction between inflammatory diseases and the whole process in cancer, but it's complicated. I think I should finish. This is the summary slide. Thanks for putting it back up.
Before you finish, Doctor, could I ask one more question?
Of course. Yes.
Could you, one thing that you haven't touched on yet is alpha-radin.
Alpha-radin. Okay, here it is. If you ask for it, here it is. So I think I have actually one more slide. Don't quiz me too much about the periodic table of the elements. I think this is supposed to, you may actually help me, okay, finding, in this column you can see calcium and radium. So there, they have similar physical properties. They're in the same column. So obviously, calcium forms throughout the bone. Radium is a radioactive isotope that I think actually was discovered by one of my compatriots, Marie Curie, in maybe 100 years ago or so when she was working in Paris. So this is one of the radioactive compounds that is called a calcium mimic. So it mimics calcium structure. So it emits radioactivity, and if you inject it into the bloodstream, it tends to home into the bone where the calcium, a lot of calcium is. The body thinks that's a calcium molecule, so it wants to store it into the bone. So it naturally targets new bone growth, which is happening around where these metastases are happening in the bone. So there is a lot of these bone reaction going on in the bone, and that's where the compound is going. So this is the cartoon showing bone with the bone marrow, that red portion, that's the liquid inside portion of the bone. Here, as you see, metastasis here. Here's magnified kind of metastasis here. So when you inject this radioactive compound into the bloodstream, it just homes into the bone metastasis area. That's the tiny little yellow dot. That's the symbol of this radioactive molecule. It is very attractive physically because, well, I shouldn't say that's maybe too much. It has attractive physical properties because it has a very short, powerful but short-range radiation. So for those of you who know physics maybe better than me, it emits alpha particles. So alpha particles, those are proton particles, heavy particles that have very short range. So they kill over short range. So they don't cause a lot of damage outside. When you inject it into the patient, you're not radioactive on the outside. You can get that treatment, go out to the street, you're not going to harm anybody. It has shown actually already, it's a European agent that was designed and developed by, I think, Norwegian company. It's already been tested in very advanced prostate cancer cases with bone metastasis. Some of these patients failed chemo. All of them failed standard hormone therapy. Again, the survival curves show advantage on patients who receive this compound. It's given as an injection once every month for 6 treatments. Very few side effects. To my knowledge, I don't have any experience with it yet other than reading about it. It is on the fast track for FDA approval. So everybody is expecting that it should be approved, within a few months, but it's obviously exactly anybody's guess because it's in FDA. But I think that's going to be a very important addition to our options for patients with prostate cancer that has spread to bones. So you can envision now, and I know I'm supposed to talk about the sequence of compounds, how to use them. And this is certainly extremely complex subject, and there are all kinds of variations. But I would say that you can envision a scenario that the sequence of some of these agents that I talked about would be as following. So in somebody who develops metastatic disease that has spreads to the organs outside of the prostate, rising PSA, you can start seeing metastasis on scans. You would typically start them on standard hormonal therapy with agent like Lupron or Zoladex. Cross your fingers and hopefully that will last for several years. If it starts failing, if it starts losing its efficacy, you would probably, these days, could make an argument in the patient who has relatively low cancer volume, that you follow them closely, they don't have pain, PSA is not that high, maybe less than 20, you would give them Provenge therapy. So that's an immune activation strategy where it provides you with long-term activation of the immune system against cancer. That is kind of a long-term slow effect, but you can kind of think of it as a backbone and building, I guess, block of subsequent therapies. But it's nice to have that active immune system in the background that is taught to fight a little bit more effectively against cancer. Then I would probably go with Zytiga these days because that's where it's already approved in this kind of setting. That can last sometimes for quite a long time. As I mentioned, I've had patients who've been on clinical trial with Zytiga who are still on the drug that originated at the time of clinical trial 3 years ago, and they're going along extremely well. So hopefully you gain a significant amount of time. Now, eventually, likely that this will start losing its efficacy in most patients. Probably my favorite step would be go to Xtandi. So that's another different hormonal agent that has different mechanism of action. Now this is a big uncertainty because we really have no data right now to know precisely how active Xtandi is going to be after Zytiga. I suspect that it's going to be a little less active than if you were to use it up front. But that remains to be seen. I think it's still going to be active in some patients, has a low side effect profile. Probably I would use it before moving to chemotherapeutic agents. If Xtandi starts losing its efficacy, probably you could make a point if you have bone metastasis. You could argue to use this agent. It's very low toxicity once it becomes approved. It also depends kind of how FDA will approve it. But in this particular clinical trial, chemotherapy exposure was not required to be on this trial. So I expect that FDA may give it relatively broad indication. All you will need to have to get access to this compound is failure to Lupron and maybe one of these previous agents and have bone metastasis. If you have that, that may be a very good strategy. Now, if that is losing its effectiveness down the line, probably at this point you're talking about Taxotere, cabazitaxel, chemotherapeutic agents. As you notice, I kind of pushed them a little bit further and further down the line of therapeutic options. And all bets are off right now about this spectacular cabazantinib agent that, that's approved. Right now it's being tested in post-chemotherapy, post-Taxotere. But that agent at the areas, I think if all goes well, it really proves its benefit on this large-scale study. That we are actually opening the Sea of Hope within the next month. We'll be one of the centers testing this agent in the large population of prostate cancer patients. I mean, that presumably will find its place. But anyway, just a very, very brief simplification, I would say Lupron or equivalent, Provenge, Zytiga, Xtandi, alpha-radin, radioactive compound, Taxotere, chemo, cabazitaxel, or Giftan. Now, that's just an example. There are an infinite number of variations and specific scenarios that could throw that sequence out of that particular order, depending on the individual patient's features and specifics. But anyway, I know it's late. Thank you so much for being so patient and for your attention. Yeah, if you have any other questions, please.
Do you use high-dose ketamazole anymore?
I do. One of the examples that I can tell you where I think it's still handy. It's the circumstance where you have sometimes patients that start failing standard hormonal therapy, but still, so in essence, they have rising PSA despite Lupron and so on, but you can't see any visible metastatic disease. Because sometimes we start hormone therapy very early these days. Whether it's right or wrong, I don't know. I'm not necessarily a proponent of jumping in prematurely with hormone therapy just because somebody's PSA went up a little bit. But that's what's happening in a lot of practices. So you have these situations where you have patients that never had metastatic disease documented. You can't see anything, but their PSA is breaking through hormone therapy. Now, those patients would not qualify, and that's purely just insurance issue. You would not be able to get coverage for Provenge. You would not be able to get coverage for Zytiga or Xtandi. You have to have visible metastatic disease somewhere to be able to say, okay, this patient has metastatic disease. Now, if you really want to do something about it, I think that's the circumstance where high-dose ketoconazole is very helpful. It kind of works, you can look at it as a cheap person's Zytiga, or it's a cheap version of Zytiga. It has a lot of similarities in its mechanism of action. It's an older drug that originally was developed for antifungal infections, but in very high doses, it actually suppresses the testosterone production in the tissues and adrenal glands, and it can be used right now relatively cheaply. It's not going to break your bank. And I've had patients on ketoconazole for years now that are very well controlled. So I think it still remains useful because of its price and because of the fact that you can use it in certain settings where none of the newer drugs, unfortunately, apply because of insurance limitations. Yes?
How do you measure the success or failure of experiment?
Well, it's essentially the same as most of the agent these days. So it has clearly, in a lot of patients, has a dramatic effect on PSA decline. So that would be the quickest way to look at. As you might have heard before here by other speakers, and also I kind of alluded to it, that we are trying to move away maybe from overreacting to PSA as the only marker of benefit. So if somebody is, for example, if you see somebody who is clinically doing well, you're not having any pain, you do the scan, and the scan shows stability of metastasis, and that's frankly good enough for me. I would continue with that even if the PSA may be creeping up. So you essentially take into consideration 3 factors. That's how you measure the effectiveness of the drugs. How the patient is feeling, how the scans are looking, and what the PSA is doing. I would say if 2 out of those 3 components are stable or better, you're probably in good shape. And I would probably put the PSA as the lowest significance, frankly, out of those 3. You can also measure circulating cancer cells. That's a little bit more sophisticated, lesser employed test, but that may be helpful to measure the effect of anti-cancer therapies. You literally take a sample of the blood and you can count circulating cancer cells using special assay. You can count, you can measure, you can look at the cancer cells in the bloodstream, and you can count them. If you see that the number goes down, that would usually be a sign of things improving. So that would be the 4th aspect of measurement of response or reaction to the new drugs that you can employ. But I don't use it routinely in my practice. It's a little more cumbersome and expensive than some other, than those traditional strategies. Yes?
Question of the scans. My wife has a fit about the radiation.
Yeah.
Because I have been
Sure. Well, I would say that is a legitimate concern, but for the most part, at least my understanding is, and I don't want to minimize this at all. We certainly don't want to expose our patients to unnecessary radiation over and over. But really, those doses that you get from scans, they are particularly, we think, dangerous to people, teenagers in their 20s, because it literally takes decades for these damages that happen from radiation to really resurface down the line. Most of the prostate cancer patients age such that probably it's not going to hurt you unless you live 100+ years. So we maybe are too cavalier about it. I agree with you that sometimes we order these scans like these are, this is nothing. But I would probably not lose a lot of sleep worrying about that realistically being a big issue for a majority of our patients in prostate cancer population. That it will hurt you, somehow down the line. Yes.
Doctor, did I understand you to say that if you had, in my case, had a PSA rising from 19, and 3 months later to 26, and when it was 19, they sent me for a bone scan and it turned out to be negative. And so I would not be a candidate then for using this Xandil?
Xandil.
Arbitral?
Yeah. Abiraterone. Well, probably as much as it's biologically you could argue you could be, but you have to show something visible these days for the insurance to cover it. That's how FDA approved it. That's the label. And because these drugs are so expensive, the Zytiga or Xtandi that costs $5,000 plus a month. So insurances will not, when you submit the request for these drugs, one of the boxes you have to check is, does the patient have metastatic disease? So metastatic means you can point something to you on the scan. Now, one thing you could potentially try to do if your doctor feels that, wow, this drug would really be maybe helpful, potentially consider some of these newer generation scans. If you can get them approved, something like MRI of the body, that's probably a little bit more sensitive than bone scan in detecting bone metastasis, or PET scans, special type of PET scans called sodium fluoride PET. You can usually get it if you're of Medicare age. You can get it covered if your doctor submits your name to a kind of registry that it's kind of like a research study.
They should go for a PET scan.
PET scan, but it's not a regular PET scan. The regular PET scans are not that great for prostate cancer, but it's a specific type called sodium fluoride PET scan. So I guess the point I'm trying to make, if you're really looking to find something, some metastasis, because that may allow you to expand therapeutic options, you may ask your doctor to order some newer generation imaging scans like whole body MRI or sodium fluoride PET. Because then if you can find something that is consistent with metastasis that was maybe not seen on bone scan or CAT scan, your doctor can check the box and say, yes, I've seen this patient actually does have metastatic disease. Then you qualify for some of these new agents. It's kind of maybe cheating the system a little bit, but not too much.
Wow, what a bunch of information we got tonight. What a great, great presentation it was. We can't afford on our budget here to pay these men what they're worth. But one of the things that we can reward them with is we can give them a little savings of time. Time is money, and so he doesn't have to sit at his kitchen table and drink his coffee. We have a prostate forum cup that he can stick his coffee in his car and drink it on the way to work.
Wow.
Thank you very much. A little follow-up before we adjourn. Those of you that attended my seminar before on advanced prostate cancer, noticed that we touched on a lot of the same things that Dr. Twardowsky did, although not quite as in detail or knowledgeable. But if you want to follow up more on what he talked about tonight, come on back to the Advanced Prostate Forum next week, or not next week, next month, 4th Thursday. I'll be